The popular narrative of the American hospital is one of terminal decline, an industry crumbling under modern pressures. The American Hospital Association reports that labor costs now account for 56% of total hospital spending. Meanwhile, government reimbursement continues to lag behind inflation, with Medicare covering only about 83 cents for every dollar a hospital spends on care. Many insurers further strain these budgets by trapping patients in observation stays, a billing status that pays a fraction of inpatient rates and forces hospitals to absorb the cost of the extra care time. Yet, in the same economic climate, a specific group of healthcare providers is experiencing a period of historic wealth. While community safety nets fail, mega systems like Tenet Healthcare are posting $3.5 billion in operating income, and private equity firms have injected over $190 billion into the sector. The American healthcare market has fractured into two distinct tiers: community facilities falling into decay and corporate systems engineered to exploit hidden market mechanics. Performance for these mega systems relies on a strategy known as payer mix. This involves prioritizing patients with lucrative employer-sponsored insurance while minimizing exposure to low reimbursement government programs. Executing this strategy requires aggressive geographic targeting. Systems achieve high-margin payer mixes by abandoning regions with unfavorable demographics and focusing on areas with high concentrations of wealthy, working-age professionals. This footprint illustrates the shift: 147 facilities in Texas and 91 in Florida, compared to just 66 in California. They target specific zip codes, building in wealthy suburbs like Dallas and Tampa to capture premium commercial insurance. In Maryland, systems follow a similar logic, building ambulatory surgery centers specifically to tap into the high household incomes of government contractors in the Washington, D.C. orbit. Under this model, the financial viability of a hospital is determined more by the demographic wealth of its neighbors than by the medical needs of its community. Smaller hospitals, unable to manage rising administrative costs on their own, are increasingly forced into fire sales to larger corporate entities. This process has concentrated power into a handful of megasystems that now control 25% of the national market, creating localized monopolies in many cities. Market dominance allows these systems to demand significantly higher prices from insurers, even when the data shows no corresponding improvement in patient outcomes. Private equity firms have capitalized on this landscape, using aggressive, debt-financed transactions to acquire vulnerable healthcare assets. These firms often use sale-leasebacks, where they sell a hospital's real estate to pay dividends to their own investors, then force the hospital to pay rent on the building. Community hospitals are transformed from civic infrastructure into financial vehicles designed for capital extraction. Shifting the focus from corporate balance sheets to the exam room reveals the ultimate cost of these profit strategies. Data from the Journal of the American Medical Association shows a 25% increase in hospital complications, including infections and falls, following a private equity buyout. Hospitals overloaded with investment debt often face insolvency, evidenced by the multi-state collapse of systems like Steward Healthcare. When profit margins cannot be sustained, systems often shutter essential but unprofitable services like labor, delivery, and psychiatric care. The only remaining options are religiously sponsored megasystems that use doctrine to restrict reproductive and end-of-life care, leaving patients with no local alternative. The coexistence of record-breaking corporate wealth and decaying community access is the intended result of a healthcare market structured to prioritize financial extraction over human wellness.